Insights from the world's best medical minds. You are watching therightdoctors.com.
Hello, good evening. This is Dr. P. Sarat Chandra here, Professor of Neurosurgery from All India Institute of Medical Sciences, New Delhi. And you're watching me on therightdoctors.com, which is India's leading medical knowledge platform. It gives me great pleasure to be here on this platform for you. And I would be speaking to you on various aspects to make the hospital environment safe for both patients and doctors, especially when we are in the current COVID pandemic. My talk would be divided into how can we have various paradigms to create a COVID ward versus COVID safe wards, and what should be the modifications which have to be done for the OPD for the ward. What is the current scenario for elective and emergency neurosurgical operations? What are the various screening procedures to be used before admitting patients? What are the protocols to be followed in the ICUs and finally in the operating rooms? This program would be of use to many doctors, especially who are surgeons, and also for the patients to give them a comprehensive understanding on how we can restructure and optimize the current healthcare and the hospital scenario to suit us or to make it suitable for the current COVID pandemic. So as you know, all of us are going through this terrible pandemic, which has been the first of its kind of thing seen by all of us during our generation, even for our earlier generation. A lot has been told in the media, a lot has been read in the newspapers, a lot of research is going on, a lot of scientific papers are being published. We are still in the dynamic stage, and every day we can see that the protocols of treatment, new treatments are emerging, and all of us are very anxiously waiting for the vaccine. And definitely it's a storm blowing over, and we are yet to see a peak in India. But obviously the question arises that how long can we wait? So we have to do some paradigm changes within our hospital healthcare systems so that we can start giving adequate services for all our patients, as well as also we should create very good platforms of safety for our doctors. So it's very important for us to divide the current hospital scenario into a COVID area and a non-COVID area. So this has become very, very essential. So for larger hospitals, if they have multiple buildings, so some areas could be designated as COVID area. For instance, at the All India Institute of Medical Sciences, Delhi, the trauma center has been converted into a completely separate COVID area where all the patients are admitted with COVID. In addition, if these patients have any kind of emergency related to any kind of disorder, it could be heart or it could be neurosurgery, treatment for these patients are again given in this place. For smaller hospitals, it's important that you have a separate wing or you have a separate block which could be exclusively for COVID area. It's important to have separate OPDs for outpatient departments for COVID patients, and all these patients should undergo a screening which includes a history, and there should be testing facilities in the COVID areas. Now, it's also equally important for us to establish COVID safe environment, because whether we like it or not, during this pandemic, people will continue requiring the routine medical consultations. They could be having heart problems, they could be having liver problems, they could be having all the other medical diseases. And as we know today, patients are very afraid to go to the hospitals because they think they could get infected by COVID. So the general rule of the thumb is that do not go to hospital as of now unless there is a serious medical emergency. It's a general request to all the public not to utilize hospital services for any kind of elective treatment. So you need to go some kind of treatment which can wait. My strong advice will be that you should wait for the next 6 months before you think of going to the doctor. But let us say you do have some illness and you do need to visit a hospital. So over here, you have to take all the precautions of wearing a proper mask, wash your hands, carry your own sanitizer, carry your own bag. And while you're seeing your doctor in the hospital, ensure that you're taking full precautions and maintaining a good distance from everybody. Now, for the doctors in the OPD environment, it's very important to have a screening area. So before the patients enter the hospital, the temperature charting should be done, and they should then be taken a history. It could consist of just 10 or 11 questionnaires, where these questions are asked to the patients: that do you have high temperature, do you have any dry cough, are you feeling unwell, have you have a loss of sense of smell, are you coming from the hot spot or containment area. So this would give some kind of cue to the hospital whether they should send you to a screening block or they can send you to the doctor. It's also a good advice for you, that if you can have a screening procedure, then you can go to the COVID safe area where you may be seen by a doctor. Now, for doctors, the general advice is that when you are seeing patients, you need to take all precautions. There has to be certain basic restructuring in the outpatients department. So you need to have a room which is much bigger and the patient can sit at a bigger distance. I have seen many hospitals who have actually installed mics so that if a patient is sitting at a distance away, you can speak to the patient at a distance. Now, when you see a patient, it's very important that the patient wears a mask, the doctor wears a mask, and he sits at a distance. The history has to be taken first, and following this, if the examination has to be done, the examination has to be done very, very rapidly in a couple of minutes. One should not try to spend too much time on examination. So the history should be completed and the examination should be over within a couple of minutes, and then the doctor should wash his or her hands and then come back to his consulting chair. I've seen certain hospitals where they have put a glass barriers. I think such kind of modifications are very good for giving long-term protection for the doctors. Uh, Within the OPD, it's a good idea, obviously, that the doctor should wear an N95 mask and he should wear a double surgical mask over the N95 mask, and preferably he or she should wear a face shield or a goggles. These two are very important to prevent any kind of splashes or aerosols getting into infecting the doctor, and likewise vice versa for the patient also. For patients, it's good enough if they wear a mask. That's it. Now, next we come to what are the modifications to be done for the ward. Now, during COVID pandemic, again, there has been a huge overall for all the general wards as well as for the private wards. Again, while we have a separate ward for COVID, within the non-COVID area, it's important to have a COVID suspect cubicle. This could be a separate cubicle which has maybe 4 or 5 beds which are adequately spaced. And this is something like a COVID suspect. So wherever some patient is admitted without a test or without ascertaining any kind of history, whether he has COVID or not, that is where the patient can be kept in a COVID suspect ward. This is especially true for government hospitals because many times you get sick patients whom you cannot refuse admission. But for private hospitals, of course, before they think of doing an elective procedure, it's important to do a full screening to ensure that the patient doesn't have COVID. The reason is that whenever we are thinking of doing an elective procedure, it has been shown by various scientific papers that if the person is asymptomatic or has COVID, the elective procedure should not be done. Because if you do an elective procedure like a major procedure, it has been shown, especially for neurosurgeries, it has been shown that the mortality, perioperative mortality or the death rate could go as much high as 30 to 40%. So that is a reason, if you think of doing any elective procedures, you have to be sure that the patient doesn't have any COVID. It's better to delay the elective procedures, or if at all you have to do the proper screening procedures. The challenge is, of course, for the emergencies. So what do we do for the patients who come in emergencies? Obviously, they have to be treated. And in many hospitals, there may or may not be facilities for screening the emergency patients. So if you get a life-threatening emergency, this patient de novo should be considered as having COVID. He should be admitted in a COVID suspect ICU or a ward, undergo surgery with all full precautions. So these are universal precautions. And after it is over, the patient could be kept again in a COVID suspect ICU cubicle till the patient is proved otherwise. If the patient is proved to be having COVID, then he or she may be shifted into the COVID ward or the COVID hospital or the COVID block, whatever is attached to the hospital. Now we come next to the ICU. What are the modifications to be done to the ICU? Now, most of the ICU in a country, we have a dormitory kind of ICUs, which is a big challenge because there is a huge chance of cross-infecting adjacent patients. So the first step which we need to do is create a separate COVID suspect ICU cubicle. So any patient, obviously you have a COVID ward where a patient with COVID infection goes there. But you have an emergency patient where the COVID status is not confirmed, they could be kept in a COVID suspect ICU cubicle. It's also important for us to do certain kind of basic modifications. I know it's very difficult to do engineering modifications. We cannot obviously, segregate the beds in an ICU by putting barriers in between, by creating walls, because that again would require significant engineering modifications. But where it is not possible, one of the possibilities is you could create glass barriers between each of the ICU bed, so that each of the ICU bed could be nursed separately. Even if you don't have a glass barrier, you could even put up some kind of a plastic barriers, so that there is a barrier like separation from one ICU bed to the other ICU beds. When taking care of patients in the ICU, it's very important to keep all the patient care equipment related to that patient separately only in the area of the patient, and the nurse or the doctor whoever takes care should be separately allocated to that particular patient. So basically, we have divided ICU into three parts. We have a COVID ICU where proper COVID positive patients who are really sick are admitted. And then we have a COVID suspect ICU where if you do not know the status of the COVID patients, they could be kept there something like a holding area. And then we have a proper non-COVID ICUs. And then finally, we come to the operating rooms. How do we design the operating rooms? I think as surgeon, this has been one of the biggest challenges for us, because most of our operating rooms are not so big. We do not have huge spaces, and most of the spaces are usually cluttered, or already we have a lot of operating equipment, especially for the older hospitals where the design has been done before. So how do we restructure our operating rooms so as to optimize it for the COVID environment? So it's very important, firstly, to have a separate donning area. So by donning area, I mean that we don't have to create a separate space. And obviously, before a surgeon goes, the entire gear of surgeon has changed as of today. So a surgeon who goes for surgery, especially in neurosurgery, they have to wear separate goggles, and preferably they have to wear special type of masks, especially when they are performing high risk surgeries, which is a 3M 6000 series half face mask with a P100 filter. A P100 filter is a very accurate. It has a filtration capacity of almost 100%, and it is attached to the mask as shown in the image you can see here. And the goggles which the surgeon wears has to be large goggles, so that they have a complete air sealing effect around the surrounding areas, so that you could also wear spectacles inside. And on top of this, it's also expected that one should wear a face shield. This is particularly important for surgeons who are working in the high risk areas. For instance, a neurosurgery would be considered as a high risk surgery, because when you are doing a craniotomy trying to open up the skull, there is a lot of aerosol which is generated. And again, when you're doing most of skull based procedures using endoscope through the nose, again, there is a lot of aerosol generation that again puts a high risk for the patients as well as for the surgeons as well as for the anesthetists. Similarly, when the intubation is going on for anesthesia, it's very important to have a separate cubicle. And this transparent cubicle is put over the face of the patient, and the anesthetist uses it. And it's very important to wait for at least 20 minutes after the induction before you start the surgery, so that the entire aerosol kind of settles down before one goes in for surgery. Now, it's very important to do certain modifications for air conditioners. Now, most of doctors, they ask, what is the safety of air conditioners? This has been debated in many news channels, and also there have been many papers published. Now, what is important to understand is that the hospital should have a good central air conditioning system. This is very mandatory. It has to have a high quality air conditioning system. Now, the air conditioning system should be put on a fresh mode, which means that it should try to take in as much of fresh air possible. The general amount of fresh air intake which is advised is about 25 air exchanges per hour. So that is mandatory. So any hospital, the engineers have to look up into this to ensure that you are only intaking fresh air. And this can be done by closing something called as a damper valve. So there is a damper valve in the central air conditioning. So once you close this, the only mode it can undertake is intaking only fresh air. And this is very, very important. Now the other thing is all the OTs have to be restructured to convert a laminar flow into a negative pressure OT. Now I will tell you what is the difference. When you have a laminar flow, it is a positive air pressure. So there is more of air pressure inside the OT. So whenever the doors of the OT is opened, the air rushes from the OT inside the corridor because there is a positive pressure inside the OT. This has been done generally for all OTs because we don't want any infection to come inside the OT. But in the COVID environment, it's very important that this should not happen because inside the OT, we have high infection rate. And if this comes onto the corridor, it could lead to all the other people walking in the corridor getting infected. So that is why the engineer has to change it into a negative pressure OT, whereby the exhaust system increases in its capacity so that the air is very rapidly drawn inside the exhaust system. So the air comes from the top and goes away almost like a suction mechanism into the exhaust areas which are kept at the bottom of the OT. So converting an OT into a negative pressure flow will be very, very useful. Now, certain air conditioners which are kept in common areas, for instance, you have the public lounges or you have even the seminar rooms. They are low quality air conditioners. You cannot put them on fresh mode because moment you put them on fresh mode, especially if you're living in hot area like most of the places in North India like Delhi or Rajasthan, if you put them on fresh mode, the cooling is going to be severely affected. In which case it can be put only on a recirculation mode. There is no option for you to convert it into a fresh mode. If that is so, in which case it's desirable to place certain exhaust fans within the room so that some air is sucked out and there is some kind of recirculation happening within that environment. Again, it is advisable not to use split air conditioners or personal air conditioners in a public area. One can use a split air conditioners or a window air conditioners in one room, provided the doctor is sitting himself or herself alone in that room. It is not advisable for the doctor to be there along with the patient in a room with a split air conditioner because then both the doctor and the patient, they're breathing the same kind of air. So it's very important to have a good quality central air conditioning mechanism. Now for clinics which do not have air conditioners, the advice will be to place a fan behind the doctor so that the airflow is from the doctor towards the patient. So that way the doctor will prevent any infection coming on to himself or herself, and the airflow will be from the doctor to the patient. Of course, here the doctor has to ensure that he himself does not have any COVID infection, and a periodic testing of all the healthcare personnel has to be done in order to ensure this. So this is briefly about how the air conditioning has to be structured. This is very important because most of our hospitals now have air conditioning mechanisms. And unless this basic restructuring is done in the air conditioning, we are again, placing all of us in a very high risk environment. Now we come, how can we do the modifications in the operating room so as to optimize it for the COVID pandemic? Now in the operating room, like I've told you, the masks have changed like in the picture which I've shown earlier. Now we need to have, this is how the masks they look like. You can put some surgical masks over the P100 filters. Now the challenge is of course how you can reuse them. So what we do at All India Institute is as soon as the surgery is over, these masks and the goggles are kept in plastic boxes. The surgeon doffs himself and then goes and washes them himself or herself completely, sanitizes them. And then we do a sterilization for about 8 minutes in an ultraviolet oven. And these ultraviolet ovens are now freely available in our country. So this is how one of the ovens look like. So you can place your masks once they are clean in this oven for about 8 minutes. And that would allow you to sanitize adequately, especially the P100 filters which you have, or you can also sanitize your masks. In addition, these ovens can be used to sanitize all the personal items of the physicians, which include purses, which include mobiles, which include spectacles, a lot of other personal items, especially when the doctors are working in high risk areas. And it takes only about 8 minutes to do proper sanitization. But before you take an oven, you have to ensure that the frequency is right. The oven has been optimized to kill especially the viral infections, because many ovens do not have that capacity, especially if you buy some of the ultraviolet sterilizers which they use in barbers in saloons. They don't have that efficacy to kill bacteria or viruses. So you have to ensure that you have taken a proper ultraviolet sterilizer which is suitable and optimized for the current condition. And it is very highly recommended that such ultraviolet sterilizers should be placed in many areas, including wards, OTs, and other public areas where you can very easily sanitize your personal objects. While recently, there have been guidelines from CDC that personal items do not carry infection much, but these are items which are limited to general public. For doctors and for healthcare workers working in high risk areas, I believe there is still a significant risk of carrying infection through personal items, and that is why it's very important to have this kind of safety mechanisms in place in the healthcare, in the hospital environment. Now, how do we make changes within the operating room in order to make it safe for us to operate during the COVID pandemic? First and foremost important thing is to have it a separate donning area. Now, when we say a donning area, I don't mean that you need to have a separate room. You could put up some kind of a standby curtains, as it is shown here, what we have done for some part of our operating rooms, where you could have sterile curtains and you could have trolleys on which you have sterile cloth, and you can keep your gowns there. So the surgeon can come here after washing and scrubbing, and then he could put on his operating suits and gowns in this place. We have suggested that there should be 2 levels of suits while coming for the OT. So a person should wear an inner suit, which is a level, we call it as a level 2 coverall. It is very important to have a 2-layered suit. One is an inner coverall and outer gown. The reason is that when we are doffing, that is when most of the healthcare workers, they get infected. So when you're doffing, you have to imagine that there could be a spillage of infection onto the inside clothes. That's why it's essential to have a 2-layered suit when you're going into the operating rooms. Now, similarly for washing and scrubbing, there should be designated areas as we have shown here. And you can see that we have stuck these stickers onto the bottom to show on what path to be taken. So obviously the traffic in the OT has to be streamlined. It has to be a one-way traffic. There has to be one point of entry and there has to be a separate point of exit. And you can see there are various posters put up on the OT to show the various donning and doffing areas. And special training has to be given to the OT personnel on how they should don and doff. And several dry runs should be done before actually applying onto live patients. So we have a separate scrubbing area where the surgeons or the nurses or other OT personnel come and spend some time in scrubbing. And then they go to donning areas where they are able to put on their OT suits. Now, for neurosurgery, because there are a lot of spills, there are a lot of blood loss, there is a lot of fluids coming onto us, a lot of aerosol generation, and they come under the category of high-risk surgeries. So that is why we prefer to wear gumboots. We put 3 layers of shoe covers. So we have an inner shoe cover, then we put on a gumboot, and then we have an outer shoe cover over the gumboots. And then over our OT scrubs, we have a level 2 coverall suit, which also has a headgear. It covers us over the head. And then we have put on another viral barrier OT gown on top of it. And we have double masks. We also have double caps, an inner cap followed by a hood, which is provided by the coverall. In addition, we also put goggles. We also put the face masks, what I've shown you, and then also a face shield. So this is the kind of protection we provide for neurosurgery, which we believe is one of the highest risk areas for performing surgeries, especially during the COVID pandemic. And this is the maximum possible protection you can give to them. Now, like I was telling you, the traffic to the OT has to be streamlined. So the way you enter is you go to the scrub area, you scrub up your hands, you wash your hands, then you go to the donning area, you enter inside the OT. Now, unlike previously, the OT traffic has to be strictly curtailed, which means that once you enter the OT, you cannot come out. So the nurses, the anesthetists, as well as the surgeons and the OT attendants and the technicians, all once they enter the OT, they have to be restricted inside the OT. They cannot keep on coming out and moving in. And any person who comes in cannot go out of the OT now. So that requires a huge amount of planning on behalf of the entire team before you start doing any surgery. So you need to keep your blood ready. So the expected blood loss, those pack of blood should be kept ready. The plasma should be kept ready. All the equipment which you think will be required for the surgery should already be inside the OT. They should not be wheeled in while the surgery is going on. And once everything is inside, the OT should be shut and then the surgery started. Now, if somebody wants to go out of the OT, and again, the exit has to be through a separate route. In fact, we have gone to the extent of converting one of our OTs into a doffing area. So when the surgery is over, the surgeon walks out of the OT, goes through an exclusive corridor into a doffing area. And this is how a typical doffing area looks. So you can see that this doffing area will have a trash can, large trash can, which is labeled as PPE disposal. Then there is a dirty chair. Then there is a clean chair. Now, the entire mechanism of doffing is very, very important, and it has to be completely protocolized. So for those of you who are interested, you could go onto the YouTube and you could look for donning and doffing for neurosurgery at AIIMS, and you'll get a nice video on how you can don and doff. But basically, the principle is that once a surgeon comes out, the first thing to do is to remove the outer gown as well as the gloves. And the gown has to be slowly inverted out, then rolled up into a ball, holding it from the inside surface, and then very carefully disposed of into the trash can. So the movements should not be jerky. They have to be slow, and they have to be very, very careful, and you have to doff in a manner so that you can imagine that there is powder sprinkled on the outer surface of the operating gowns. And when you're doffing, you have to prevent this powder from spilling onto the ground. That is the kind of imagination you should have. So you should not do any kind of sudden jerky behavior, sudden jerky actions, which could lead to a risk of the infective material falling onto the surgeon. So once this is done, then again the hands should be sanitized, a separate fresh pair of gloves should be worn, and next the shoe covers have to be removed. Once that is done, again remove the gloves, sanitize your hands, clean your boots with sanitizers. That's what we do. Sanitize your hands, wear your gloves again, and then next remove your head cap, then remove your coveralls, remove your goggles, and finally you have to remove the goggles, N95 mask and your outer surgical mask, and then put on a fresh mask. So what we do is we take the goggles as well as the face masks, put it in large plastic container, seal it, sanitize the outer surface of the container, then take it to the scrubbing station, where the surgeon spends at least 10 to 15 minutes washing and scrubbing and sanitizing the goggles as well as the masks. And then we put it inside the ultraviolet sterilizers for about 10 to 15 minutes, and then finally seal it in a plastic pack to be reused again for next surgery. Now, excuse me. So now once the surgeon comes out, it's very important that he follows. He or she should not talk to anybody. He should follow the one-way traffic, go to the changing room, take off his gown or take off his OT scrubs, have a scrub, have a bath. It's very important to have a shower, good shower, and then walk out of the OT. So this kind of a strict regimental protocol is to be introduced in the OT atmosphere, which would be safe for both for the healthcare workers as well as for the patients. So this has been the purpose of my talk, to give the adequate amount of information which has been targeted both at doctors as well as the patients. And in my talk, as you can see, I have covered about dividing the hospital into COVID areas and non-COVID areas, on how we have to restructure our OPDs as well as wards. What are the modifications we had to do for our central air conditioning systems? How to do a triage for elective as well as for emergency surgeries? What are the basic screening mechanisms? What are the basic changes we have to do within the ICU as well as the OT areas? And above all, of course, we should not forget to follow all the usual mechanisms which is being shown on the adjacent slides, where one has to follow the universal precaution of washing hands frequently, wearing a mask, maintaining proper distance from everybody. So if these protocols are followed, I know they are a challenge because they are a new normal and we had to get used to this new normal in a very short period of time. I know the whole world has changed in just a matter of 1 to 2 months, and it's constantly changing. It's a dynamic process, constantly changing. And we are all wary of what would be the situation in the next few months to come. But I believe that if these precautions are taken or followed carefully, the risk of having or developing an infection would be minimal. And that is very important for a doctor or a healthcare worker, because unless a doctor or a healthcare worker is not safe, not protected, doesn't take adequate precautions, how can he or she provide that kind of care to his or her patient? So thank you once again for watching the rightdoctors.com, and it's been a pleasure for me to give this piece of information to you. Thank you very much.
Insights from the world's best medical minds. You are watching the rightdoctors.com.